think let's have a quite an engaging conversation over the next 20 minutes. If you have any questions, can they also have mics? Yeah. If you have any questions, please raise your hand. Someone will come to you so that you can actually ask your questions in any language of your choice, except others that we don't understand, please don't ask. All of these things that my esteemed faculty spoke about, these all sound very fancy and fascinating. Madam, your NGS, Jeyaseelan's latest modality taste, TARE, Dr. Suneesh's ADC, immunotherapy, your proton therapy, yours, all these latest fancy things, theranostics. What is the missing X factor here? I feel it is the cost. How much has cost of care affected your ability to practice medicine the way you want it to be? Can we start from here?
Actually, the important question we need to answer.
Especially in our system, we don't have insurance. Most of the patients are paying out of pockets.
So they say whether you can cure. There is no answer for it. So we have to tell them we have to do the imaging. If recurrence is there, we have to treat it again. So then they will ask again, it will be another 1.5 days. So is there any other solution? So that issues are there. So only way to address is improving our health insurance scheme and government support. Now Ayushman is there and central institutes are getting better coverage through Ayushman, but penetration is poor. So that needs to improve.
So, in terms of pathology testing, patients, it is very hard to convince patients that after the initial biopsy, you need to do additional tests. And I am sure there is a lot of heated discussion in front of the pathology billing section. How is this cost factoring in your ability to freely do things? Can you give a practical example for this?
Yeah, I think so. One thing what we do is when a biopsy comes and the patient starts asking for reports, the clinician also when we get calls. So most of the time we have an initial diagnosis, but we need further. Like for example, to start with, we need immunohistochemistry. Immunohistochemistry has sort of become like very normal thing to do, and most of the markers we have in-house. But again, the cost is sometimes an issue. So mostly we tell the clinicians to speak to the patients, because when we tell them, it is like already we have paid. Now what else do you need to know? So immunohistochemistry, at least we do get the patients finally doing. It's only a very small handful of patients who leave the hospital without doing that. But when you go to the molecular techniques further, that is a very, it's like I want to start PCR. Most of you know, I think I have already begun that using the PCR machine, which is there in microbiology, because it has not been being used much after the COVID upsurge. So I wanted to do the JAK2 mutational studies in that, but cost was one very important factor, because thing is, we are competing with private labs, which has they have a lot of business models by which they can give a lot of discounts and rates which are very affordable. But then the thing, the volume is very, very, like I was asking one of the private labs which we sent outsource, and they were saying the company people, they were saying like in one floor they have about 50 PCR machines. So just imagine, they do so much every day, so they are able to cut the cost. But then when we start something, cost is a major factor. So not only in an individual patient, I think in the further going forward for pathology itself, to add more tests to our repertoire and do it in-house, cost is a factor. So as Jeyaseelan told, probably we will need these insurance and all this, and then it depends on the place we are working. So in a hospital like MOSC, it is difficult. Most of the patients to take money from their pockets and pay for this. So it is a limitation.
Often we have to support patients significantly to do the diagnostic testing. Most of the insurance doesn't cover diagnostic testing. That is a flaw with our insurance schemes also. Even government insurance schemes does not help with diagnostic testing. It will only help with treatment sometimes. Dr. Suneesh, now you have experience with counseling on immunotherapy. You know that there is a possibility that immunotherapy will work, but you have to explain to them. Does it take a lot of your daily time talking, counseling, explaining? What is your experience about this cost of care issue?
Definitely, what I have seen is the cost of this basic treatment, bare minimum treatment has come down very much. Like chemotherapy, all the drugs, that has come down very much, and the supporting care also is affordable for most of the patients. But when you come to the newer molecules and immunotherapy, all those things, the cutting edge technology will not reach, have not penetrated the common people yet, and you cannot practice those kinds of things in a community-based hospital like ours. But I think the revolution of what is happening in the world, the same thing in the politics, all those things are happening in the health system also. Now we are seeing more and more Eastern Asian products that is coming not from the Western side. Those molecules are more affordable for our class of patients, and more techniques that we are using from the what we say from the China, all those countries, that is having equal results with the Western drugs. And in near future, I think our markets will be flooded with those products, and more patients who are in the, at least in the lower middle class of people, will be affording that kind of immunotherapy and targeted medicines. But I feel it is difficult for our, at least in our setting, it will be very time consuming and making them understand to spend this much of money for a person who is diagnosed as a stage 4 cancer. Our difficulty is convincing them to get at least some treatment for a stage 4 cancer comes first, rather than discussing the further getting an immunotherapy.
Now, Dr. Arun, as a radiation oncology colleague, I personally never thought radiation doctors would have substantial difficulty explaining cost. But having worked with you, I've realized how much you have subsidized care for our patients in Kolonjani. So you also feel the burden of cost of care even for radiation techniques?
Yeah, see, it's a reality. Now, if you can afford, if you are somebody who afford a 5-star hospital, you go a 5-star hotel, you go for a 5-star hotel. If you want to go to a Takeda, you go to a Takeda. Health is little bit different. Irrespective of your affordability, you all want best care, and that is the reality. In radiation oncology, cost comes from multiple things. If you have to think about cost reduction, radiation oncology is a high capex department because the machine costs around 20-25 crores. So somebody who is investing on 20-25 crores for a machine is looking for something. If you can somehow take that out of the equation, the operational expenditure of radiation oncology is quite less. You don't have many trucks to buy, many consumables or anything. Your investment is in machine. So if you are a charity institution and you can, your machine cost is not at your concern, then you can actually bring down the cost. Basically there are only 2 or 3 companies available who produces a kidney taxator. So one is Varian, one is Electra, third is Accurate. There is an Indian company called as Panelists who is producing a device called as Siddha 2. Most of us even doesn't, buy it. Most of us won't support such initiatives. But if you have to bring down your cost, you have to bring down your cost of your initial capital expenditure. The third thing that we do to reduce the cost is actually to reduce the number of fractions, like I told before. Because once you're reducing the number of fractions, cost is not just a function of this patient's treatment bill. This patient has to travel every day for treatment. This bystander will have to take leave every day for treatment. So you just reduce the number of fractions, you actually reduce the cost in multiple ways. The other thing that we do is what Aju discussed. You have to understand the billing code of your hospital. So if you because all hospitals now work with billing codes. So if you understand the billing codes, you can always play around and reduce the cost of the system. That is what I usually do for when Aju codes for a patient.
That's a secret that Arun just declared aloud, but please don't let his hospital know what he does. Sandeep, now your challenge as a medical oncologist, when I look at how you practice or surgical oncology colleagues practices, you talk about a lot of the common costs of surgery. But then there is a lot of chance for the unintentional complication. Right? And cost of care is also challenging. Some of these robotic techniques are fantastic options. But how can we get that to the common people?
Like everybody said, cost is the main biggest problem in India. When the patient comes to my OPD, they will ask they'll incur everything what is about open surgery, laparoscopy surgery, robotic surgery, and what is the outcome of the surgery. I explain everything. Then the last question comes, what will be the cost for each? When I tell the cost, approximate cost, robot is out of the picture. There are two problems. I think all these robotic platforms, there are more than 60 robotic platforms which is running across the world. And the most acceptable platform is the Da Vinci platform, which is mostly used worldwide, which is in India also. Other platforms they are using in Europe, and there are multiple Chinese platforms also. Out of these, we don't have any platforms except SSI Mantra, and in comparison to SSI Mantra to Da Vinci, everybody has the same opinion that our platform is not up to the mark, like the precision, the time lag, is not matching the efficiency of Da Vinci. So one thing is the research and innovation is lacking in India. When the more companies they will put more fund, they will infuse more money into this research and development. Probably in coming 10-15 years, the cost will come down. It has come down, but still it is more for our socioeconomic status. And that is one thing. And second thing is insurance. Now there is a law in government of India that insurance cannot, the companies they cannot deny robotic charges. But what they are doing is, when somebody is taking 20 lakhs or 30 lakhs of insurance, the insurance company is saying that only 20% or 30% charges of robotic platform will be paid by the insurance, rest 70% of the robotic charge will be paid by the patient. When you are taking insurance more than 50 lakhs or 1 crore, in that case, only your robotic charges will be, they will be giving all the money. When the person is taking insurance, they are not telling this thing. When it comes to pay the hospital, that times all these clauses and all those things are coming. So that is one problem. So
that's very interesting. I have a patient now who has a 1 crore insurance, but patient's insurance doesn't pay anything because there is a small print that says
exactly
that only 2 lakhs, up to 2 lakhs of monoclonal antibody therapy is given. So patient has insurance 1 crore, 0 use. That's the sad part about it. So if you are taking health insurance, advice is take it at a very young age, read the fine print and broaden the coverage. Vijay, is this a problem in your hospital or where you practice cost of care and how to manage that?
Yes. I wouldn't say hospital. I would just speak about my department per se. So yes, because nuclear medicine right from day one, when we started PET-CT in Kerala, Amrita, that time the scan was around 30,000. That is more than the therapy cost. So we're using a diagnostic modality which is costing more than the therapy itself. But then, this is multifactorial. I mean, definitely the government needs to pitch in, but then they have a limit. And again, the insurance companies, and you need a lot of support. So the team you're working with, they should be on the same page. The administration, they should understand what you're trying to do. Definitely, they have put in an investment, as you said. The machines are not cheap. You're paying a lot for the machines, so they have to get back the cost, but then it's still doable. And another thing that I feel is still untapped is, and you are associated with a lot of NGOs, So the society per se, at least in our culture, we can come up together and support groups. Because people, we know, there are people who want to help, but they don't know whom to approach because they don't want the money to be misused. So that is an option that is still untapped, I feel. And a lot of support groups can come up, and if people like us would go and tell them, they need somebody whom they can trust. And then the funds would come in. So that is something that we can still tap into, I feel.
Yeah. Vijay and all of us here are part of several large NGOs. Vijay is part of something called Butterfly Cancer Foundation, which is one of the leading NGOs in Kerala who spend or provide care for worth crores of rupees to patients who deserve care. And thank you for doing all of that. If there is any question, please raise your hands, or else I'll just move to the next one. Next sort of question I have for the panelists. Alright, this is a question not about the science, but about the practice of medicine, about your personal life. Cancer or healthcare is a very challenging situation. Even a pathologist who is not seeing patients directly, you are also hearing a lot of stories. Elizabeth, madam, you have umpteen number of times you have called me and asked me about patients. you've seen a slide, what is this patient, how is she doing? It bothers you a lot, right? How do you de-stress? What is the challenge as a doctor that you face? Is it stress? Is it time? Is it emotional challenges? Is it staying updated? What are the various challenges? This is an out of syllabus question. What are the various challenges you face? I'll start from you, Jay.
So, this is again personal. How you manage stress? I mean, each of us will have our own hobbies or vents to let out. Definitely, I mean, being humans, we would be concerned about how a patient. Even I am just with imaging. I just give a report. But then, when I give a report, I hand it over to say a young lady. I would be concerned because I need to explain to her, tell her what the options. Sometimes they'll ask us, doctor, what are my chances?
Can you hear, by the way? Okay, yeah.
So definitely there's an emotional component involved, and it's a personal thing. But then it's important, as you brought it up, that we as clinicians, we should take care of ourselves also. We need to have some sort of a vent to let out. I mean, it's a personal thing. I can't speak on behalf of anybody else, but I like to spend time with my family. Whenever I get an opportunity, I run home, and that's how it's a personal thing.
Sandeep, how do you de-stress? I know you're a pretty chill person. Surgeons are generally considered the chillest of the people around. So.
No, I mean, definitely, like Sir said, there is an emotional component to it. For my distress, I take physical activity. Like Arun sir knows, I go for cricket, I play badminton, football, whatever game I know, I play. But apart from that, it's different when a patient comes to my OPD and he gives or she gives consent for surgery. Literally, she is giving trusting me with his or her life. So that's a responsibility I have to deliver to his or her expectation. But as a human, you cannot get success all the time. Sometimes you have done a very good surgery, but the patient will get an nosocomial infection, then the patient will die. I have a couple of cases like that. A very good people surgery, a very tiny 2 mm pancreatic duct. You did a very good anastomosis. There is no leak, nothing. Day 5, day 6, patient is taking food, walking around. Day 7, everything is okay. Day 8, you are planning for surgery. Day 9, the patient develops fever, breathlessness. Day 13, patient goes to ICU. Then forever. Then after that, patient drinks. When patient shifts from ward to ICU, believe me, the charges goes like it's like rocket. That patient, that particular case, what I am telling the patient when I was supposed to discharge, the bill was like around 6 lakh or 7 lakh for Whipple surgery, which is okay. Patient went to ICU. After 13 days, the bill went up to 30 lakhs. The patient, the patient got candida. There are two infections. One candida infection, one is Burkholderia infection. So we lost the patient. So in that case, sometimes though it is not my fault, but still the patient has trusted me for something. So in that case, I take few hours, maybe few days to get recovered from it. I have my own ways. But then that's the reality. I mean, sometimes you have to face it. And as an individual, you have to find out our own way. For some people, it is music, art. For me, it is physical activity, games. So it's like goes on.
Arun, what about you?
I think what Sandeep was telling was that Sandeep is a very good fast bowler. And if the patient is giving him stress, that day evening he is going to bowl even faster. So it makes life really troubling for the rest of the people facing him rather than him. But to be honest, see, all of us adjust. Most of us, have our own shield. There is a level till which we allow this personal relationship to grow. Beyond that, we sort of shield ourselves from all these emotions. But in between, if you are medical students, you should always go and see that Patch Adams, where Brian Robbins talks to the medical board. Frankly, that is the best thing for a medical student. You have to always understand there is a human at the other end. They have a story. And actually, radiation oncology is not a disease specialty. I actually allow people to talk. In fact, many times I let them, because my terms are usually very busy, so I have more time at my hand. So I just let them talk. And talking to people actually helps you. I mean, it de-stresses you. Once they talk about what is happening in their family, or some of them is a sitar player, or somebody had some business. All these things actually, helps you relate to them as human, and then you accept certain things. The most difficult thing is if you are having a pediatric patient, then you are stuck, because all your other justifications will not work when you have a kid with cancer and he has got a difficult issue. Then it is at times difficult. But the other thing that I try to do at least is that, see, if you are awake for 10, 12 hours a day, 8 hours you spend at your hospital, with your workplace, with your colleagues. So can you make a happy department? If your department is happy, the rest of the things are okay. You can always manage around that. But if you have stress in your entire co-working space and it is a pressure cooker, by the time you come in the evening, you will have to shout at your wife, and then your wife will shout back at you, and then this will lead to a set of events. So to me, a happy department is the key. Talk to the patient, allow them to talk. That helps me out a lot.
Arun is one of the rarest of the rarest radiation oncologists who actually talks to patients. So, Suneesh, you have a very challenging job managing very complex discussions. How do you de-stress? Suneesh may say, I don't de-stress, or I am always stressed.
No, sir. Actually, I was following you to find out the ways to. Actually, there is a saying in medical oncology that if you have a troublesome wife and a troublesome pathologist, your lives will be screwed.
I used to speak to Manita.
So I am blessed in a way that I have very good. I have a very good pathologist and a very good wife. So my life is.
I think that's a cause for applause. Thank you. Suneesh, do you have a comment for that? And then.
I knew this would happen with Suneesh. She always scores at the end. Before answering this question, your previous question, I was just thinking afterwards. I have worked in the UK for some time, so I think the cost factor, what we all talked about, there you just don't have to worry about the cost because it's all insurance based. So it is like you see a tumor, you want to do 6 markers, 8 markers, you just give the lab the instructions because that is not at all a factor in it. So here we always have to think, can I do it 2 markers, 3 markers, should I go to 5 markers, then the cost up. So I think that is one area because that was a very great difference I feel. There you don't have to worry about the cost. You have to send for molecular test, you just send it because it's all insurance covered. The patient doesn't have to pay a dime from his pocket. Okay, so coming to this question, how do you de-stress? So see, all of us in the medical field, I think, be it a doctor, other healthcare workers, everybody see cases. For us, most of the time, they are just names. We don't have faces linked with the names. We see in the request form a name, and then we've not seen them. But we see a tumor. Actually speaking, the first thing a pathologist, when you look into the microscope and see a very rare tumor, the other day also it happened. I think I said, oh, in the banya kana. That is our first response. But then you think, oh, this is a tumor, this is a person. And there has been a lot of instances, I still think of a boy who had come from ENT department. He was it was missed for some time. He had a tumor. Finally, it turned out to be neuroblastoma. Even now, I think, we don't know. So, all of us in the medical field are told, you can have sympathy but not empathy. So, and we, in some way, and with time it happens, at my age, at my stage, having completed so many years, I have found ways to cope up. And initially, the instances were more, where we have all learned in association. And we do but then it gradually comes down, because we sort of develop a barrier. And we say, okay, that is it, this is my profession, and then doing some random shopping. It is happening. like involuntarily. After some time, it's like driving. No, initially you're thinking about everything. After some time, finally you realize you're driving and you're thinking about something you didn't even notice that you would hit the brake when there was something on the road. So that it becomes like that after some time. You learn to dissociate. I always tell my junior colleagues, like the moment you come from your house to work, okay, in the car you put on some music, you listen to that music, you come here, so your mindset is your house. But the moment you come up the stairs of that in front of Dean's office, no, you switch. Now you're starting to thinking about the hospital, the departments, the cases there. You forget your house. So each one has their own ways to de-stress, and most of the time, I think we sort of learn how to, and then and as Arun told, I was thinking the department where you're working. So that is one thing I'm so blessed. I always tell, the moment you get into the reporting room with all my, I call them my kids, they are there. It's like, no, you look forward to coming to the department. So coming to the department is not a stress. So the day you have that, that means you're blessed. Whatever else you don't have here, that is, I think, something which needs to be given value to. So you're similar to, like, you like to go back to your house, to your husband, to your kids. Similarly, you like to come to work. So that balance, that is important.
Jeyaseelan, you're always at work. How do you
Basically, as an IR, we are always dealing with high-stake situations. Whether it's a stroke, aneurysm, limb ischemia, even GI bleed. So during initial days of practice, it was difficult. When you do all your effort and patient is not recovering, you will feel low. But over the period of time, I understood it's a part and parcel of your practice, and the best de-stressor is next success story. Next success story. So if you treat the next patient, the patient is doing well, you are seeing smiling patient, you will forget about the past one. So that's main thing. And of course, families, their friends, and social media. So those things you can use it.
Now I'll come to my last part of this panel discussion unless you have questions. Almost 50% of the attendees today are nursing students or nurses. All of you may or may not have some interaction with nurses or nursing students. What are tips, advice, tips you can give to them based on your area of specialty? Do you need nurses' help in your department? If so, what is expected of them?
Okay,
There are a lot of nursing students. I think it's important that we can give them some tips so that they can learn or understand what we want from them.
So at least in my case, it's pretty unique because nuclear medicine, we do need nursing staff, and when you say nuclear medicine itself, most of the administration doesn't enter a department. Most of the doctors don't enter a department because there's always a nuclear and radiation. So unless it's absolutely necessary, nobody enters. And the same concern goes on to the nurses also. So even when they get posted, often there is the concern that am I going to get any radiation? So one thing you need to understand is whichever department, not just nuclear medicine, whichever department you're going to, I mean, it's always an experience, and you have to learn from. There's nothing wrong in being afraid, but it's when you have knowledge about the subject, then you get over the fear. Now, not just nuclear medicine, yeah, others. So try to learn all aspects, all departments. I mean, right now, when you're a student, it's too early to select one field and say that, I'm going to stick only to this. So it's an opportunity, visit all the departments and learn. And as far as nuclear medicine is concerned, one thing is, yes, we are handling radioactivity, but we take precautions also. So learn, and again, it depends upon the group. You learn to trust a group, work as a group, and you use the opportunity to learn. Every department has its own pros and cons, and you never know where you excel. And again, nuclear medicine, like most of the nurses whom I have worked with, when after starting the department in Rajgiri, I moved on to the UK and other parts of Europe. And since they have a background in nuclear medicine, which is quite rare, they are actually doing well. They are, in fact, they have a few skills which they tend to teach to others. So it's always an opportunity to learn.
Sandeep, for you, you need specialized nurses sometimes.
Yes,
right?
yes.
What
yes.
tips do you have for them?
For me, the patient care is the most important thing. And cancer surgeries are very invasive surgeries sometimes when you go into thoracic cavity or abdominal cavity or multi-organ dissection. In that case, post-op, initial 3 or 4 days, till the patient is in ICU or out of the ICU for initial 2 or 3 days. It is very important. Like sir said, to take care of the patient, we have to have efficiency, and that comes with experience. And I tell my sisters, you have doubts, that's okay. You can just call me anytime. 2 o'clock, 3 o'clock at night, you are finding something difficulty for any silly reason, just call me, I'll come. But the patient should be comfortable. And when you give a patient a diagnosis of cancer, the patient will have a lot of queries in their mind, whether I'll live or not. If I live, whether it will be a good life or a bad life, whether I'll get back the cancer, what if it comes back. So most of the time, if they are not able to ask the patient, ask the doctor, they will ask the nurses. So for onco cases, onco surgery cases, the patient, the sister has to have a lot of patience, and he should be very eager to learn things, new things, and with that, she will become more confident to take care of the patients. So,
I like for radiation oncology, do you need nurses?
Absolutely. In fact, and MOSC nurses are well trained. I have nurses from MOSC with me. They're actually, seriously, they are good. I have seen them. One thing, like from what Dr. Vijay told, in radiation oncology, you will have zero exposure to radiation. Realize that, although it has the name radiation oncology, the highest exposure will always come from radiology and gastro because of the procedures they are doing, not from radiation oncology. It is a safe department from a radiation exposure point of view. Second thing, in radiation oncology, you must, part of your work is like surgery. There is a brachytherapy happening. Part of your work is like radiology. You have to give contrast and administer the things for a CT scan. And the part of your work is like regular nursing. So there is a learning curve to understand all these things because all of us, forget nursing, even MBBS students, we don't get posted in radiation oncology. So we have no clue what is happening in that specialty till we reach there. So that barrier is there. So it takes times to learn that. Third thing is understand the context of treatment because you talk to the patient, because I tell this to almost everybody, talk. You talk to the patient, understand the context, understand why you are treating. Don't just go and put a catheter or put an IV fluid or put an this thing. Because good thing is in radiation oncology, these patients are coming every day to you. So you can understand the context and then, that actually makes you better. You can give the care once you understand why you are doing something. I have a system where actually every Saturday, in fact, this is happening right now, 11 to 1 o'clock, this will be happening in my department where the entire department sits together and discusses all the cases, including the nurses, including the technology, including everybody. That actually helps my staff nurses to understand what is happening. Fourth thing about nursing in general, what I have seen, what has changed recently is that many people are teaching the nurses, it doesn't matter whether you do it or don't do it, just go and document it. You go to many places, nurses will be sitting and, doing multiple forms, NABH forms, JCA forms, this form, that form. And when you're going somewhere, you don't get the nurses to accompany you. Nurses don't know anything about it, but everything is recorded. And this is being officially taught by everybody. Even if you don't do, just do the recording. Honestly, if you ask me, that is the biggest mistake we are doing. We are just recording things without actually doing anything. If you can change that habit, it will be great from the nursing community.
Very valuable point for our nursing students and nursing team here. Suneesh, your thoughts?
Yeah, definitely. Oncology nursing is a specialty that is growing very fast, and the role of nurses in oncology here is very, very important also. Because most of the time, our patients are they are spending more time with our nurses rather than with the doctors. So what I feel is, in our department, the patients are more having more rapport with our nurse rather than me in sometimes. What I feel, because how the nursing staff in our department is taking care of the patient. So what I feel is the students who are interested in practice and oncology nursing, they should have a better communication skill, and they should have better knowledge of the subject, at least bare minimum knowledge of the subject. And most important thing is they have to understand the emotions through which the patients are going. The more they are communicative to the patient, that will have a different scenario. Because the center where I have trained, I was working with a very wonderful team. And the patients who are long-term survivors who are coming to our OPD will definitely go to our ward and see the nurses there. That was, I was seeing so many patients coming to the ward and seeing the nurses, and they will chat with them, and that was very touching scenario what I have seen. So that means not only the doctors, the nurses are also remembered in most of the time, because they are giving the primary care. They are relieving the symptoms mostly, because after giving some medications, all those things. What I feel is they are the first person coming to their problems. So that kind of relation, that kind of rapport, that has to be developed by the nursing students.
So, madam, do you have nursing needs in your department?
No, actually speaking, we interact with them mostly as students. So it's like a teacher-student relationship for us. We don't have nursing after their studies. Nobody works like in the pathology department. So they come to us in the third sem and then we teach them. It's like theory classes, but with the change in the curriculum, we teach them some aspects like this, because in the fifth semester we have genetics, which pathology has to take. So in genetics, there is always that role of nurse in each aspect. So it's sort of like the eighth form of MBBS, the attitude, ethics, communication part. So I think we do give you some tips as to how to, like later on when they become nurse proper, like when they take up a job, how to do those things. So but otherwise, and then they have projects in our department, so that time they get a glimpse of what we are doing. We do send them for projects to the labs and all that. So that is it for us.
Jeyaseelan, last.
So the IR field means basically most of the times we'll be working in cath lab. So the field is more or less similar to cardiology, but the thing that differs is we'll be doing every day different body systems. Someday we'll be doing brain stroke, someday aneurysms, someday bronchial artery, someday. So the procedure is new. So the thing is, the nursing staffs, they should be eager to learn. So every day there will be a learning. So cardiology, there's a fixed procedures. Probably they'll be dealing with MI, so they know the pattern. But when it comes to IR, every day it will be a different procedure, some new experience. So always be updated and try to learn and asking questions frequently. That is more important.
Thank you. I think we conclude our panel discussion and the morning's proceedings. Over to Dr. Sini to conclude the morning proceedings, after which we will have the lunch. Please join us for the lunch in the stadium. Dr. Sini.
Thank you, panelists, for sharing your valuable learnings and also the challenges you face as care providers to give optimal treatment to patients.